Assalamu alaikum, good morning, whatever the time is right now. We are continuing on with our ophthalmology clerkship video sessions, and today we'll be talking about anterior uveitis, which is the continuation of our red eye theme. This is going to be a four differential. We start off with conjunctivitis, keratitis, acute angle closure, and then anterior uveitis. When we talk about uveitis and the red eye, we specifically talk about the acute anterior uveitis. But since we are talking about uveitis, we'll cover the entire disease spectrum, including something that might not even produce a red eye. So bear with me. This is what we're going to be doing today. Although it might seem to be a pretty extensive list, uveitis, honestly, at an undergraduate level, is not that extensive a topic, simply because we tend to limit ourselves to some things that can be identified with a torch and a good history and other simple ocular examinations. There are certain things that need to be done in a little bit of detail and certain really important signs that can unfortunately only be picked up with a slit lamp. We'll show you those here in order to complete the discussion and also especially the management. But our focus is going to be on signs that are relatively easier to pick up. So we'll start off with the UVL anatomy and the UVL tract. Basically, the word uvea comes from uva, which is grapes in Greek. And it is called as such because if you dissect the eye out, it looks as it's a bunch of grapes. It is composed of three parts: the choroid, the ciliary body, and the iris, each doing its own specific things. Iris basically controls the amount of light entering the eye. The ciliary body aids in accommodation and production of aqueous humor, while the choroid does a lot of things. Essentially provides nutrients to the outer four layers of the retina. We've talked about this when we talked about diabetic retinopathy, although not in a lot of detail, that the inner six layers of the retina are supplied by the central retinal vessels and the outer four layers are supplied by the choroidal vessels. We also talked about this in detail when we did retinal degenerations. It also helps in removal of waste, something we also touched upon in retinal degenerations, and heat dissipation. You know, the fovea and the macula are really active because as long as you are awake, your eyes are working and they're generating heat. And even if you close your eyes and there is light in the room, your photoreceptors are still working, recognizing light, identifying light. So they do generate a lot of heat which needs to get out of the eye, and because choroid is providing a lot of blood circulation, blood flow, it helps to dissipate heat as well. This is the blood supply of the choroid, and it's basically composed of anterior and posterior circulations, and we'll just do that here. The posterior bit, or the posterior circulation, is basically the posterior arteries, the long posterior ciliary arteries and the short posterior ciliary arteries. The short posterior ciliary arteries pierce the eyeball around the optic nerve. They supply the optic nerve and also form a part of the choroidal circulation. The long posterior ciliary arteries, they supply the choroid and the ciliary muscle, the muscles of the ciliary body, and then they join in to form the major arterial circle of the iris. The anterior ciliary arteries are basically branches of the muscular branches of the ophthalmic artery, and as compared to posterior ciliary arteries, which are direct branches of the ophthalmic artery. So the anterior ciliary arteries branch off from the muscular arteries. They supply the recti muscle, the conjunctiva, and the sclera, the episclera as well. And then they join the posterior ciliary arteries, the long posterior ciliary arteries, to form the major arterial circle of the iris. So this is the blood supply. You should be better at it than I am. My anatomy is pretty rusty by this time. So we'll see in a little animation so as to identify the various bits of the UVL tract. So this is the sclera, and the first thing we'll do, we'll dissect of the sclera, and this is how the choroid is. It's all around underneath the sclera, and it's composed of all these tons and tons of blood vessels, which are organized into three layers, basically: large capillaries, large vessels, medium-sized vessels, and choriocapillaries. So now we have removed the cornea and the aqueous humor, and we are looking at the iris. We will remove the trabecular tissue, which is the white line, and the canal of Schlemm, which is the blue line. And now we have the iris in between the ciliary body, and behind is the choroid. So this little thing in between the iris and the choroid, this right here is the ciliary body. And all of these things are obviously three-dimensional. We'll remove the choroid. This is the retina. We'll remove the retina. Then we'll get to the vitreous humor. We'll remove that as well. And these are the zonules that are removing the optic nerve, zonules that hold the lens in place. So those are the next to go. And now we have, this is the posterior aspect of the ciliary body, and this is the iris. Remove the lens, iris, and ciliary body. And now what we're going to do, we're going to try and look at a cross section of the ciliary body. And the ciliary body basically has two parts, a part that has folds interiorly. This part right here, this is called the pars plicata, and we saw this when we talked about open angle glaucoma, because this is the part that produces the aqueous. And the part behind it is pars plana, this part, flat part through which we inject things into the eye. So this is pars plana, this is pars plicata, and this is the iris attached to the ciliary body. So these are the various components of the UVL tract. And this is another look, and we've seen this diagram before. Look at the pars plicata, the part of the ciliary body with the folds, and the pars plana. So what is uveitis? Uveitis is basically inflammation of all or part of the UVL tract. And this disease entity is very interesting. You would think that uveitis is limited to just the UVL tract inflammation of choroid, iris, or ciliary body, but no. Because this entire choroidal UVL tract is sandwiched between the retina and the sclera, and these tissues are really close together, as you saw in the animation, although animations are not the best thing to look at. I'm sure you've seen histological sections, but these tissues are like sandwiched together. So if you have inflammation in the UVL tract, that inflammation can spread towards the sclera, or more commonly towards the retina. And because the retina is in very close association with the vitreous, and the vitreous also touches the ciliary body, as we saw in the animation previously, the anterior face of the vitreous is right next to the flat part of the ciliary body, the pars plana part. So if you have inflammation in the ciliary body, it will get into the vitreous. If you have inflammation in the retina coming from the choroid, it will potentially get into the vitreous cavity as well. So it's an entire spectrum of diseases where the origin of inflammation is in the UVL tract, but it can spread very easily to adjoining tissue. So it's not just limited to the UVL tract per se, it is also possibly, and most of the time, extends into the tissues that surround the UVL tract. It usually lasts for a couple of weeks to lifetime, and the reason for that is that most of these are associated with autoimmune diseases. So you have remissions and relapses. Some people or patients are really lucky that they only get one attack in their life and they never get another attack, even though they have an associated systemic condition. And some people just keep on getting it. And many of these people actually don't even have a confirmed diagnosis, so they just fall into that idiopathic or unknown category, in spite of taking a good history and doing a very good clinical workup and a lab investigation and radiological workup as well. Talked about this associated with autoimmune diseases or idiopathic, and there are conditions which are associated with infections, systemic or ocular. And we'll talk about them as we go along in our discussion. How do we classify uveitis? This has again been a point of contention, and a lot of terminology and a lot of classification systems have been around for a very long time. But the classification is basically based on the one that's accepted, widely accepted, and that is by this really big workshop that happened in a conference in which they had a lot of ophthalmologists from, I think, that was 11 countries, and they came up with one sort of consensus on the terminologies to use, and that's basically based either on the anatomical part of the UVL tract where the inflammation arises out of, and the duration of the inflammation. So anatomical is anterior, intermediate, posterior, or pan. Pan would involve all of the layers. We'll talk about what's anterior, intermediate, and posterior. And duration would be acute, which is sudden in onset and has a limited duration of less than 3 months. Recurrent, which has repeated episodes, which are sort of interspersed with areas or time of inactivity, and that inactivity period should be 3 months or more, and that inactivity should be without treatment. So you have a patient of uveitis, you treat him, the inflammation is completely cured, and then you have a period which is 3 months or more in which he is taking no treatment, he or she is taking no treatment and has no signs or symptoms of uveitis. So that's recurrent. A chronic is a persistent uveitis. A persistent uveitis is one whose duration is more than 3 months, and it relapses within 3 months of stopping treatment. So rather than becoming recurrent, in which you have a greater than or equal to 3 months duration of no activity without treatment, here the disease comes back before 3 months or within 3 months of stopping treatment. So this is the way we classify it on duration, and you usually combine these two methods. So you call it an acute anterior uveitis or a chronic anterior uveitis. So this is a visual representation of how an acute uveitis would look like. So you have sudden appearance of signs and symptoms with a limited duration, and then the patient is healed. He's just good. This flat line is a healed state or an inactive state, and this is where the patient has the active illness and the duration is less than 3 months. This is recurrent, where you have repeated episodes, but the in-between time, the time between the interbellum, the time between episodes of inflammation is 3 months or more, and this period does not have any active or any treatment being given to the patient. This is chronic, and you have persistent uveitis in which the duration is more than 3 months. So persistent uveitis is one in which the duration of the disease is more than 3 months, and it relapses before 3 months of discontinuation of treatment, and it also might continue as a sort of a undulating, remitting, relapsing phase without any breaks in between. So this is another way of looking at the classification of uveitis with respect to the duration of the disease. So this is how we classify uveitis. Remember, we said anterior, intermediate, posterior, and pan. So this is anterior uveitis, and in the brackets you have the primary site of inflammation. So anterior uveitis, the primary site of inflammation is the anterior chamber. The anterior chamber is the space between the cornea and the iris, and we have talked about the anterior chamber before, specifically when talking about cataract and cataract surgery. The clinical features of an anterior uveitis are something called anterior chamber cells. Together with flare, we'll see what that is. Chorotic precipitates, peripheral, anterior, and posterior synecdoche. And the disease entities included in anterior uveitis is iritis, inflammation of iris, iridocyclitis, inflammation of iris, together with the anterior part of the ciliary body, the part of the ciliary body which has the folds, and anterior cyclitis, which is just the inflammation of the anterior part of the ciliary body. Then we have intermediate uveitis, which was once called pars planitis. The primary site of inflammation here is the vitreous. So you get vitreous cells and something called pars plana exudation. Pars plana is a flat part of the ciliary body, and you have exudates on it because the two disease entities in this anatomical classification are posterior cyclitis, inflammation of posterior part of the ciliary body, and something called hyalitis. Hyalitis is another term for vitritis. Posterior uveitis, the primary site of inflammation is retina or choroid. The two disease entities or the clinical features that you see are of choroiditis and retinitis, and the disease entities are choroiditis, chorioretinitis, and retinitis, either inflammation of choroid or retina separately or together. The reason I've really not put these things here is because they appear very differently depending upon which layer is sort of inflamed first, and you can't really sort of put down terminologies here that would apply to all these disease entities. And panuveitis implies all of the layers are inflamed, all of the layers, all of these disease sites can be involved. And this is basically from standardization of uveitis nomenclature. And you can obviously attach the disease, the duration prefix to these. For example, again, acute anterior uveitis, chronic anterior uveitis, so on and so forth. This shows the two types of uveal inflammation associated with the ciliary body. Pars plicata inflammation causes anterior cyclitis, which is a component of anterior uveitis, inflammation of the part of the ciliary body with the folds. And then you have posterior cyclitis, which is inflammation of the flat part of the ciliary body, pars plana, which is a component of intermediate uveitis. And although it's not shown here, this is where the vitreous is, where the cursor is moving, and it's in very, very close contact with the pars plana. So vitreal inflammation, vitritis or highlightis, can easily spread onto the flat part of the ciliary body, pars plana, causing posterior cyclitis. These are all the categories of uveitis: anterior, chronic and acute, intermediate, posterior. Our main focus during the discussion is obviously going to be anterior uveitis. These are the disease entities, and obviously at the top of all of these, you see idiopathic unknown. And then you have other specific disease entities, ocular and systemic, and their most common tests that can help diagnose these. We'll talk about these when we talk about specific disease entities. We'll start off with anterior uveitis, and these are the disease etiologies together with recommended tests, and we will continue to talk about these as we move on. We'll start off with acute anterior uveitis. Acute anterior uveitis is associated with a lot of seronegative spondyloarthropathies, and RF negative implies seronegative. So these individuals are RF negative when you do their serology. And the disease associations are ankylosing spondylitis, psoriatic arthritis, inflammatory bowel disease, and its associated arthritis, reactive arthritis, which was formerly called Reiter's syndrome. It's not called Reiter's anymore because it's been said that it was described before Reiter, or Reiter was accused of war crimes after World War II. He was a German, so take your pick why it's not called Reiter's anymore. Behçet's or Behr's disease, this is after a Turkish scientist who first described this, and phacogenic uveitis. We talked about phacogenic uveitis when we were talking about cataract, specifically the Morgagnian and the hypermature and then the Morgagnian variety, in which the lens proteins were leaking out of the lens capsule and inciting a very strong inflammatory reaction in the anterior chamber. The acute anterior uveitis is the most common type of uveitis that's diagnosed, up to 90%, depending upon which population region you look at. And most of it obviously falls in the idiopathic category. About half, if you investigate them well and get proper tests done, may be associated with HLA-B27, have HLA-B27, hemoleucocytic antigen B27. Males more commonly affected than females. The ocular condition that we have already talked about is phacogenic uveitis. The systemic conditions are the spondyloarthropathies. RF negative spondyloarthropathies are ankylosing spondylitis, which is most commonly seen associated systemic condition. And ankylosing spondylitis is basically inflammation of the spinal joints, which fuse the spine, and rather than a flexible back, you have something like a bamboo spine. So it's very rigid. Inflammatory bowel disease, I'm sure you've done Crohn's disease, ulcerative colitis. Reactive arthritis, Reiter's disease, is large joint inflammation together with cervicitis or urethritis, depending upon which genitor you are looking at. Psoriatic arthropathy is scaly skin and any joint inflammation. Scaly skin because the cells of the skin replicate at a very fast rate, so you get red, itchy, scaly skin. Behr's disease or Behçet's disease is basically oral aphthous ulcers in your mouth together with genital ulcers. Depending upon which population region you see, Behr's disease may be more common in females or in males. The theory of autoimmunity in uveitis is one of molecular mimicry, but it's not been clearly elucidated. And I'm sure you know what molecular mimicry is. It's a foreign protein that sort of cross-reacts with your own innate proteins or self proteins or peptides, and they can activate your immune system. How do a patient with an acute anterior uveitis present? Well, irrespective of the etiology, the patient is going to present with a red and a painful eye together with decreased vision. it is usually that one eye is affected by uveitis. You can have the disease alternating between the two eyes if you have recurrent attacks. And you can also have a bilateral presentation in which both eyes are affected. You are going to have a lot of photophobia. The patient is going to present with a lot of photophobia, not you. And by the time we talk about why the photophobia happens, you can think and come up with a clinical reason for it. There is a possibility of recurrence, and the recurrence is usually in the same eye. And what happens is you have several recurrent episodes in one eye, followed by several recurrent episodes in the other eye. You might also have pre-existing symptoms, and obviously when you're examining signs of an associated ocular systemic condition. But the thing is, just like with diabetic retinopathy, in which diagnosis of diabetes was established in an eye clinic, the diagnosis of a systemic association is usually it usually begins in an eye clinic because the uveitis presents before the systemic disease presents. And the said systemic disease is then diagnosed later, simply because if you are a good ophthalmologist, you are alert and you can tell the patient, oh, you might have another association, so go see a rheumatologist as well. And even if you're a family physician and you are seeing this patient for the first time, and you can pick up an acute anterior uveitis, and we'll tell you and teach you how you can pick one up on torch. With a lot of confidence, you can tell the patient that in addition to an ophthalmologist, you should also consider visiting a rheumatologist, especially if you can elicit a history of one of these systemic associations. And even if you can't, and you sort of already know an association, or you're aware of associations between uveitis and systemic diseases, you should tell your patients, because again, communicating with your patients effectively is just as important as your clinical acumen. So this is a patient, or an eye of a patient who's presenting with acute anterior uveitis. And you have all these arrows that I've already marked, and all you need to do is identify what sign or what lesions or what abnormalities are these arrows pointing to. You can pause it right here, or you can just listen to what I'm going to say. We'll start off with the blue arrow, and this blue arrow is showing circumcorneal congestion, which is also called circumciliary congestion, which is also called limbal congestion. We have seen this in keratitis. We've also seen this in acute angle closure, and we know this happens, well, we know by now why this happens. We'll talk about why this happens if you sort of can't think about it right now. The green arrow is basically showing you a hazy cornea, although not as hazy as something that we saw in acute angle closure or in a keratitis, a full-blown keratitis, where because of infiltration and abscess formation, you can't really see anything during an active disease. Here, it is mildly hazy because you really can't make out the iris in good detail. This is the most important sign, a small irregular pupil. And we talked about a small irregular pupil when we talked about acute angle closure, because a patient presentation of an acute angle closure and a uveitis, the way he comes to you with pain, redness, photophobia might be very similar. And if you're a primary acute angle closure, it's so similar that you need to differentiate between the two. And the most common presentation of an acute angle closure is a primary acute angle closure, especially to a family physician clinic. So you need to be able to differentiate between the two based on the appearance of a pupil. In primary acute angle closure, the pupil is mid-dilated, non-reactive. Here it is small, irregular, and non-reactive. It is irregular, myosed pupil. Why is it this way? It's going to come up. You have time to think about it. So this is basically an outline of a normal-sized round pupil, and this is our irregular, myosed pupil. The black arrow points to something that's usually not visible on a torch. These are called keratic precipitates. These are actually lesions on the endothelial side of the cornea, and they're usually, not always, they're usually present in this inferior zone, inferior triangular zone, which is called the Art's triangle. And again, this size of the pupil is really, really essential to note and to pick up. This type of pupil, actually, not just size, is really essential to pick up when you look at a patient during a torch examination presenting with an acute red eye, because you need to be able to differentiate between a primary acute angle closure and an acute anterior uveitis. This is unfortunately something that cannot be seen with a torch at all, but is really, really important. And these are basically presence of cells and flare in the anterior chamber, which is called the anterior chamber reaction. If you look at this picture right here, or this is the light being reflected off the cornea. This is of the slit from the lens. This is a slit lamp picture. I'll show you a video how this was done. This is from a very good website called rootatlas.com. It's run by an ophthalmologist. It's sort of been neglected somewhat recently, but it has a lot of useful information. So, and this is the anterior chamber, the gap between the cornea and the iris and the lens. And this is a normal anterior chamber, and you don't see anything in the anterior chamber because anterior chamber allows light to pass through without any reflective medium in it. It has aqueous humor, but the particles in the aqueous humor are so small that they really can't be picked up with on a slit lamp examination. This is an anterior chamber reaction which is seen in acute anterior uveitis, and as you can see, you see some round things, lesions. These are cells, those inflammatory cells in response to the inflammation in the anterior chamber. And this blue arrow points towards this haze, which is flare, all the proteins that are leaking out of dilated vessels. So this is called the anterior chamber reaction. Anterior chamber reaction is important because this is the best sign to see how well your treatment is working, because you would want the cells to disappear, because cells disappearing is telling you that the inflammation is now going away. For the patient, it is basically the redness going away, which is also a very good sign. But for the patient, the redness going away is the thing that tells him, oh yeah, the disease is sort of now quiescent. Pain is not such a good marker because you're going to give him something to reduce the pain anyways. So redness and right now here, these cells are very good markers to see how well your treatment is working and where the disease is heading. So this is going to be a little video, and I'm going to show you a video. This is a slit lamp examination. And these are all the cells in flare. This is the light coming off the cornea. This is coming off the lens. And I'll just pause it here, move it slowly forward in time. These are the cells, these round structures. And all this generalized haze, that's the flare. Cells, lots of cells, and this generalized haze in this light beam between the cornea and the lens. If you see this little rectangular area, it shows this haze, which is basically all the flare. So I'm going to pick up this picture here as well, and this picture is taken about here. So you can see all these cells, which is the white arrow, and the generalized flare in the background. So these are the cells that are appearing here, and this generalized background haze is the flare. Flare usually goes away later because flare is just the proteins or the X trans 2A that's coming out. It's the cellular reaction that disappears first that tells you it disappears if your treatment is working and the disease is sort of, now sort of under control. So sometimes what happens is you have a very severe reaction and you get a hypopium. We have seen a hypopium form now more than a couple of times. We saw one in keratitis. We saw one in endophthalmitis when we talked about cataract, complications of cataract surgery. You also see it in uveitis. And irrespective of the etiology, whether it's infective or not, the hypopium of a uveitis is usually sterile. And this happens because there's such a lot of inflammatory reaction going on in the anterior chamber that the cells and the proteins tend to settle down and form a little collection in the anterior chamber, which is called a hypopium. It just indicates that the inflammation is pretty severe. Of the acute anterior uveitis, Behçet's disease or Behet's disease is something that's pretty commonly associated with formation of a very small hypopium. But it can form in any of these etiologies that we have talked about. So these are all the patient presentations that we have seen: circumcorneal congestion, chorotic precipitase, cells in flare, hypopium formation in case of severe inflammation, an irregular small pupil, which is also myosed and poorly reacting, which is the most important thing, as we've talked about, a hazy cornea and pain and photophobia. So why do all of these things happen? Now is the time to compare your answers if you came up with any. Circumcorneal congestion is simply because of all the reasons that we have been talking about before. The inflammation is within the anterior chamber. So the only sign you're going to get outside are those dilated vessels at the limbus. Chorotic precipitates are all the inflammatory debris within the anterior chamber that tends to stick to the corneal endothelium in the direction of the aqueous flow. Thus, they are seen mostly inferiorly. And remember, in inflammation, tissues are sticky, so this sticky sort of debris tends to stick to the corneal endothelium. Cell and flare are just inflammatory reactions in response to inflammation. Flare is basically the leaked proteins. Irregular meiose pupil is the most important thing to remember, and that is happening because inflammatory mediators, prostaglandins, act on the smooth muscles of the iris to constrict it. Now, you might ask, iris dilator is a smooth muscle. Why doesn't it act on the iris dilator and dilate the pupil? Well, it could, but the sphincter is a much more powerful muscle as compared to the dilator, and the action on the sphincter is much greater, and thus you have a small pupil, and that makes the pupil small. Why is the pupil irregular? We talked about this when we talked about acute angle closure, and I hope you remember that inflamed tissues are sticky and edematous, so they get close to the lens and they stick to the lens, and wherever they stick to the lens, they just remain there, and that causes its irregular appearance of the pupil. Inflamed iris is sticky because inflamed tissue is sticky and forms a connection with the lens, posterior synecdoche, and we've talked about posterior synecdoche before, to give it its irregular appearance. You have a hazy cornea because of loss of sodium-potassium pump in response to inflammation, and because of loss of the integrity of tight junctions because of inflammation in the anterior chamber. Pain in photophobia is because of iris spasm. We talked about why iris is spastic when we talked about why the pupil is small, or meiose number 4, see up, because of action of prostaglandins. That's one. And the photophobia is because of the same reason. Light goes into the eye, it wants to make the pupil even more constricted, causes even more pain. So exposure to light causes even more pain. Raised IOP may also cause pain, but as you will see, and we have seen before, the IOP is not raised in all patients. In fact, in most patients, the IOP is not raised at all, especially in a setting of acute uveitis, acute anterior uveitis. Photophobia we have talked about. So again, we have seen this before. The IOP in uveitis can rise either because you have debris accumulation into the anterior chamber, or the trabecular meshwork itself might be inflamed, which is just a carryover reaction to the trabecular meshwork. You might have posterior or anterior synecdoche. Posterior synecdoche is between the iris and the lens. Anterior synecdoche is between the cornea and the iris in the periphery, peripheral anterior synecdoche. Posterior synecdoche causes iris bombi accumulation of aqueous behind the iris. We've talked about this before, pushing the iris forward, causing blockage of the anterior chamber angle. Anterior synecdoche, peripheral anterior synecdoche directly block the aqueous flow because they shut off the access of the aqueous to the anterior chamber, because the iris and the lens are stuck now. The iris and the cornea are sort of stuck to each other in anterior synecdoche, sorry. And this is mostly seen in chronic uveitis, where there is an enough opportunity for these things to establish permanently, and rather than, you know, happening on and off in a setting of acute uveitis. The IOP generally does not rise, and that's simply because of ciliary body shutdown. Inflammation of any of these tissues can extend iris, or the posterior part of the ciliary body, the iris, the inflammation in the iris in anterior uveitis can spread to the pars plicata, or the part of the ciliary body which is producing the aqueous, because they're right next to one another, and cause ciliary body shutdown. Inflammation is loss of function, and the IOP doesn't rise. And that happens most of the time in a setting of acute anterior uveitis. So this is an example of peripheral anterior synecdoche, PAS, this black line, and you can see the entire angle on this gonioscopic view. This quadrant of the angle seems to be blocked. So this is one mechanism in which IOP might rise in uveitis, and this is the iris. This is a gonioscopic view. We have done gonioscopy, and I'm sure you remember what a gonioscopic view was. This is posterior synecdoche. This is between the iris and the lens. And notice how the light beam reflects over the iris. It's convex forward, so the iris is being pushed forward because the aqueous is accumulating behind it. And this line, this yellow line, is showing you how the light reflex would normally appear had the iris been flat. And it basically follows the path of the light as it comes off the lens, because you see the lens in its place, the lens is in its normal place, It is the posterior synecdoche between the iris and the lens that stops the flow of aqueous. Remember, the aqueous comes from posterior chamber to anterior chamber between the lens and the iris. It can't do that now because the lens and iris are sort of stuck to one another. It's accumulating all behind the iris, pushing the iris forwards, causing the light reflex of the iris to be convex forwards rather than being flat. This light ray, the final light, this light beam is obviously coming off the cornea. So now we'll talk about chronic uveitis, and then we'll talk about how we manage anterior uveitis, both the chronic and the acute types. So this is the classification of chronic anterior uveitis. Idiopathic unknown is number 1. Juvenile idiopathic arthritis, sarcoidosis, syphilis, and tuberculosis. Chronic anterior uveitis is a persistent uveitis, that is a uveitis of greater than 3 months duration, in which a relapse occurs within 3 months of stopping the treatment. The systemic conditions associated with chronic anterior uveitis include juvenile idiopathic arthritis, which is an arthritis seen in young girls of age less than 16 years. It's usually an oligoarthritis involving 2 to 4 joints, and the joint inflammation period is at least 6 weeks. So you have to have joint inflammation for at least this much period without any identifiable cause to have a diagnosis of JIA. The other cause is sarcoidosis. And remember, sarcoidosis together with the other 2 following causes are great masqueraders. They can present as any form of uveitis, but the most common presentation is the chronic anterior uveitis. And sarcoidosis is a multi-system inflammatory disease in which you have non-caseating granulomas. The most commonly involved organs include your skin, your eyes, your lung, and your lymph nodes. Then you have syphilis, Treponema pallidum. It's a spirochetal infection, and tuberculosis is Mycobacterium tuberculosis. So these are the associated systemic conditions. So the duration is more than 3 months, and the patient presentation is a little different as compared to an acute anterior uveitis, in the sense that the inflammation is milder, it's of a chronic type, the pain is less, the redness is less, but the visual loss is something that's significant. So of all of the 3 things, pain, redness, and visual loss is at the top of the list. Pain and redness come after that. And the keratotic precipitate have been traditionally described to be larger as compared to that of acute anterior uveitis. I'll show you a picture of comparison, though it's of dubious quality. The evidence is of dubious quality with regards to the size of the keratotic precipitates. So this is a difference between an acute and a chronic uveitis. Onset is acute and insidious. Pain is marked, minimal. Photophobia is marked and slight. The photophobia is again slight because the inflammation is minimal. And remember, photophobia was happening because a spastic iris muscle was forced to contract more in response to light. When your inflammation is minimal, the response to light, the pain response to light would be minimal. Circumcorneal congestion again are minimal. Keratotic precipitates are defined as non-granulomatous in acute uveitis and described as granulomatous in chronic uveitis. They're also called mutton fat and small and hyaline. But again, as I said, this is of dubious quality, this evidence. IOP, intraocular pressure, usually normal or low, depending if the ciliary body has been shut down, and it may be raised. It's usually high as compared to in a setting of acute uveitis, because of secondary glaucomas. And this is usual is a comparative term, right? It's not a definite term. It's usually in comparison to an acute setting. In fact, I think I should put it here just before you say, oh, we didn't hear you say it. You should have written it. There we go, written, usually in italics compared to acute uveitis, and usually high. So these are those mutton fat or granulomatous keratotic precipitates seen in this inferior zone in a chronic anterior uveitis. And you can notice that there is not much of an inflammation. That circumcorneal congestion that we saw in the pupil is sort of also not as improperly shaped as we saw in the acute setting picture. So these are the KPs or keratotic precipitates of an anterior uveitis. These are those of a posterior uveitis. Again, I said that the evidence that these are really differentiating features is sort of dubious. chronic uveitis, anterior uveitis KPs are also called granulomatous. Acute setting uveitis KPs are also called non-granulomatous because they're short. They're called mutton fat because they have the color of a mutton fat. We don't usually see mutton fat, the color that those people who describe these as mutton fat. It's because we don't let our meat hang. We slaughter, we eat. If you let the meat hang, let the blood drip out, it's said to taste better. I haven't tasted it, I think, but so I wouldn't know. I have tasted it, but I honestly couldn't tell the difference. So how do we manage these patients? And because there are so many systemic associations, taking a good history and taking some time on a history is essential in uveitis. In ophthalmology, usually histories are supposed to be brief, crisp, because all the decisions have to be made in an outpatient basis. We don't admit and take a hour-long history and do an examination and then order investigations. The decisions have to be taken within maybe 5 to 10 minutes of seeing a patient, because you can't make a patient wait very long. And since you're not going to admit a patient, the patient knows that, oh, come on, let's just get done with it. But here we need to take a more comprehensive history, because we need to figure out, does the patient have any symptoms or a history of any of the systemic association of these diseases? So a careful history is important, and there is really nothing here that's out of the ordinary. So I'll just go and talk about not all of these points, any points that I feel are sort of important, and emphasize on them. For the present uveitis that the patient is presenting with, the onset is important because it tells you, are we looking at etiologies of acute disease or a chronic disease? Past ocular history is again important because it tells you, has this happened before, and you can associate it with one of the acute or chronic etiologies that we have talked about. Trauma is important because trauma can actually introduce many infectious agents, and surgery can do the same. Medical, again, TB, syphilis, sarcoidosis, very important. Take a good history. Syphilis, especially in our setting, you might think that syphilis is not rampant or something that you see here. You see a lot of syphilis here. People just don't give a good sexual history. They are reluctant to do it. That is why you don't get a history of syphilis. And you need to take the patient into confidence and take very careful, and what's the word for it? A very ethnologically and ethnologically safe history, so that the patient does not feel uncomfortable talking to you about it. So you use terminologies and terms and sentences, or phrase or construct your sentences so as to appear as what's the term for it? What am I looking for? As modest to the patient as possible. But syphilis is something that's a little problematic. Sexual history again relates to syphilis. Drug abuse used to, you're injecting IV, you can get an infection. Travel history is important because certain infectious agents are seen in certain regions. For example, somebody traveling from Europe to Asia, TB is something that they would think of. Age, young girls think of JIA. Most of the other diseases usually happens in adults. Gender, again, certain male and female predispositions, as we have talked about. Family history, again, we'll see one of the examples that we've already seen, ankylosing spondylitis and other diseases. They might have a genetic component, so might run in families. Again, infections, in history of infections, syphilis, tuberculosis. So syphilis, not that much. It just might give you a hint as to actually what the family's been up to, but it's very wrong to associate one family member's history to another. So history of tuberculosis is more relevant here. These are just review of systems. Again, nothing out of the ordinary that I can basically think of. All of these are related to TB. These are related to various joint inflammations. And if you can pick out specific joints, for example, joints of the spine, large joints, medium joint, it might give you a hint as to which of the systemic association you're looking at. Dermatologic association is psoriatic arthritis. Neurologic is something that can be because of sarcoidosis acting on the central nervous system, or even syphilis. Respiratory is sarcoidosis because it can cause shortness of breath and a cough. GIT is basically inflammatory bowel disease. Genitourinary can be Behr's disease, or Reiter's syndrome or Reiter's syndrome. So once you have taken a history and you want to do some workup, how do we go on about it? If this is the patient's first attack and you've taken a good history and you can't come up with any evidence of systemic association, don't get any workup done. You're wasting it is spending patients' money and time on something that might never happen again. So as most of the diagnosis is idiopathic, so let's not get anything done. But if the patient is presenting with a chronic uveitis or it has systemic signs or symptoms, you can refer to the table that we did before and pick and choose what sort of investigations to do. These are just general guidelines. When your patient is in a idiopathic category, you can't really come up with something, and you're presenting with maybe a chronic anterior uveitis or recurrent attacks. So you think of these. Again, nothing here that's out of the ordinary. I've pretty much explained why you're doing and what you're doing it for. I've put multiple sclerosis here, although multiple sclerosis usually does not present as an anterior uveitis, but you can have a little bit of a spillover attack. And we'll talk about spillover when we talk about multiple sclerosis in just momentarily. So these are the workups. And again, nothing here that you probably haven't heard of before. So management of a patient with uveitis, not only anterior uveitis, but all types of uveitis, even those that we will discuss later. So we're just putting it here at the beginning of the management section, is that you need a multidisciplinary, multi-specialty, and a multimodal approach. And that is because of the various systemic associations that you see with uveitis. And in fact, when the disease is not being diagnosed and it's frustrating the ophthalmologist or the family physician, the involvement of other specialties is also more important. So I've listed some here. You might even need to have a contact with more than these, depending upon what you're suspecting in your patients, or what has been diagnosed in your patient. But you would need a rheumatologist for sure, because you have spondyloarthropathies. You will need an ID specialist, infectious disease specialist, if you're suspecting TB or syphilis, a neurologist, tertiary syphilis or multiple sclerosis, a pulmonologist if you're suspecting sarcoidosis or TB, a dermatologist if you're suspecting or has been diagnosed with psoriasis, psoriatic arthritis, a GI specialist if your patient has inflammatory bowel disease. So see the number of specialties that have to be involved in this really a very difficult disease to actually manage, because of all of these associations that can be present with it. And that's why it's so frustrating for the patient and the clinician. For the patient, because it's a disease that might come back, it is a recurrent disease, it's a chronic disease. And for the clinician, because trying to find a diagnosis or even manage an idiopathic status is difficult, especially so when you have so many clinicians involved, and the clinicians and the patients and the patient and the clinicians among themselves are not really talking. Not only verbal communication, but if written communication is not effective, then you can end up in a lot of trouble, simply because all of these doctors might be giving the same drugs. So if the patient is getting a lot of same drugs, especially if the patient is somebody who is not literate, or even if he is literate, he is so frustrated that he is just taking everything that's been given to him. Or at times you're giving the drug with a trade name, a name that is available from various companies. Generically, they might be doing the same thing, although the compound might be different, and the patient might not be aware of it, and the patient might not be carrying multiple prescriptions from one doctor to another. And that is why the clinicians amongst themselves should have very clear communication. And the best way to do it in our country like Pakistan, where the patient does not have a central file or a central history, is to make sure to tell the patient to create a file in which you have a general history, clinical findings of all the clinicians involved, what treatment are they currently prescribing, and that goes to the various clinicians. Unfortunately, it becomes the patient's responsibility, because that's the type of health system we have, but it's essential so that everybody knows what treatment is the patient taking. And not only that, you need to communicate about the disease itself to the patient. So overall, it's not the easiest disease to manage. It's pretty frustrating, and it requires collaboration amongst a lot of clinicians, and they need to be clearly communicating to one another, especially if they're not in one healthcare facility and they're located at different places. How do we manage these patients? Obviously, the patient is presenting with two things: pain together with decreased vision, pain and redness together with decreased vision. So we need something for pain relief, and pain is because of iris spasm. So we need to release the iris spasm. we need to relax the iris muscle. So you give cycloplegics. Short-acting cycloplegics are usually preferred for acute uveitis and even for chronic uveitis because they keep the pupil mobile. If you give a long-term agent, for example, atropine, what might happen is that the pupil might be dilated for so long that it'll form peripheral anterior synecdoche. And if the pressure is high, consider anti-glaucoma drugs. We need to reduce inflammation, and this is one of the diseases that usually does not work without steroids. So you can give topical, oral, or periocular depending upon the severity of the inflammation. One eye or both eyes are involved. Periocular injection is just like the injection for anesthesia for cataract surgery. And obviously steroids have to be gradually tapered off once you start. You don't just stop steroids because you get adrenal crisis. If you have side effects for steroids or steroids alone cannot control inflammation, you can give methotrexate, azathioprine, and cyclosporin. The reason I'm not basically prescribing or ascribing specific dosing here is because uveitis is something that is best handled or managed by an ophthalmologist. So you might, what's the word for it? Diagnose it, but it's recommended that you let a specialist treat it. If you pick up a specific ocular or a systemic association, infectious association maybe, for example, a systemic infectious association, for ocular association, if you pick up phacogenic uveitis, you need to control the inflammation, do cataract surgery. For specific infectious causes, for TB, you need to do anti-tuberculous treatment for 3 months if it's only ocular. If it's a systemic TB, it's full-time. Syphilis is the treatment for neurosyphilis, which is intravenous penicillin G, 24 million units for 10 to 14 days, and this goes IV. And this is what happens once you start giving treatment. The inflammation reduces. Remember, redness together with cells, disappearing cells in the anterior chamber are the best guides to a disease that's getting under control. And the pupil is dilated because we are giving cycloplegic agents, mediatric agents to be more precise, so that the pain can be relieved. This is a better picture showing you what happens when you start giving mediatric drops or dilating drops. These regions that the arrows are pointing to approximately was the point where the posterior synecdoche had formed, the connection between the iris and the lens, the stickiness of the iris and the lens, the sticking points of the iris and the lens, where the iris was stuck to the lens, posterior synecdoche. And when you start dilating, the synecdoches break, and you can see how the synecdoche or the areas of attachment between the lens and the pupil are stretching, and they will break eventually. And these are the areas of clearing, so the aqueous can now start flowing out from here, 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 and relieve the high IOP, if any existed. What are the complications? The complications are usually seen after recurrent attacks of acute uveitis and more commonly in chronic uveitis. And you have cataract formation either because of recurrent inflammation or because you've been taking steroids. And the management of cataract is a little tricky because you can't do cataract surgery in an acutely inflamed eye. And even if you do cataract surgery after the inflammation has sort of quieted down, there's always a risk the inflammation would come back. Remember, if it's a chronic uveitis or a recurrent uveitis, any manipulation might bring the attack back quicker. So you have to be very careful. Even if the disease is quiet, you gave a little bit of steroid prior to surgery, and steroids after surgery are always given, so maybe give them in a little higher dose. Intraocular pressure is very tricky because, as we have talked about, that it may or may not rise. And the cause of rise we have already discussed, maybe a secondary open angle or an angle closure. Angle closure is peripheral anterior or posterior synecdoche. Secondary open angle is if you have either been taking steroids or you have inflammation of trabecular meshwork or deposition of inflammatory material in trabecular meshwork. So either of these things can cause a secondary open angle, and you manage this appropriately by using anti-glaucoma therapy together with uveitis therapy or therapy for uveitis. Prostaglandins are not used together when you have active disease because prostaglandins themselves are mediators of inflammation. Macular edema is something very interesting. You have inflammation in the anterior part of your eye and your macula becomes edematous. And this is something similar to what we did in diabetic retinopathy, in which VEGF was flowing from the ischemic retina all the way to the iris to produce new vascularization in the iris. Here, inflammatory mediators are flowing from the anterior part of the eye through the vitreous to the macula, and causing macular edema. And these appears as little cystic spaces, which I'll just show you. This is just a loss of foveal reflex, showing you that your macula has lost its normal concavity. This is the normal macula, remember, it was concave on OCT. These are the cystic spaces with fluid, and this is how it appears on an FFA, and it's called cystoid because these are little cystic spaces in which you have dye collecting the cystoid macular edema. You can give anti-VEGF injections because that will sort of control the vasodilation. The anti-vasodilatory effect of an anti-VEGF can control this. But most of the time what happens is once you control the uveitis, the macular edema sort of subsides on its own. If it doesn't, you can give these injections. We'll talk about intermediate uveitis, though it is not our primary focus, simply because it's more of a posterior segment disease, more of an involved disease. Enough information for you so you can pick it up in a patient who is presenting to you in your role as a family physician. So intermediate uveitis is inflammation of the posterior part of the ciliary body, posterior cyclitis, or the vitreous associated with next to it vitritis or hyalitis. And the most commonly associated conditions that you see are sarcoidosis and multiple sclerosis. See above would obviously mean when we were talking about the larger table. Sarcoidosis we've already done. Multiple sclerosis is an autoimmune disorder which destroys the myelin sheet around your nerve, slowing nerve conduction down. We'll talk more about multiple sclerosis when we talk about optic neuritis because they have a very close relationship with one another. And multiple sclerosis is something that might actually initially present as an intermediate uveitis. So how do the patient with intermediate uveitis presents? The visual loss here is painless because the iris isn't involved, iris is not spastic, no pain. And the eye is not red because the inflammatory reaction is now not in the anterior chamber. So although this is not a typical presentation of a red eye, we are studying uveitis, and the most common presentation of a uveitis is red eye, and we need to sort of, rather than break a disease down into so many bits to make it complicated, we are just putting all the uveitis here. It's just like, when you do integrated medical curriculum, some things are really weirdly placed. For example, I've heard here in the university that you're affiliated with, this college is affiliated with, you do heart with the musculoskeletal system, which is really weird. Although heart is a muscular organ, it's so much more appropriate to do it when you do the cardiovascular system because its role is more important there. So similarly, rather than break this down into sudden painless loss of vision and discuss it there, it's just being discussed here because it's a part of a greater disease, and it is possible that this disease spills over into the anterior chamber and cause a red eye. And that is what we have written here, that although the most common presentation of an intermediate uveitis is a painless loss of vision, while loss of vision, we'll just talk about it, in a quiet eye as the iris is not inflamed and not spastic. But this inflammation, because the flat part of the ciliary body where the inflammation is in intermediate uveitis, pars plana, posterior cyclitis, is attached to pars plicata, which can cause anterior uveitis, which is attached to the iris. This inflammation can easily spill over into the anterior chamber and produce pain and redness. The major complaint that these individuals have is one of floaters, and floaters occur because the inflammatory cells are now in the vitreous, intermediate uveitis, and the patient would complain of seeing thousands of little, not thousands, tens and hundreds of little mosquito or fly-like objects, black in color, floating in front of their visual fields. And that is because of all the vitreous activity. The cells are in the vitreous. And although, again, most is idiopathic, it is associated with multiple sclerosis, which is a demyelinating disorder of the nerves. And actually, in addition to the neurological signs and the signs that you see in eye of optic neuritis, this might be the first clue that the patient is actually developing multiple sclerosis. Multiple sclerosis is usually seen in middle-aged women. So a middle-aged woman presenting with an intermediate uveitis should alert you to the possibility that this patient might go on to develop multiple sclerosis, because this might be the first sign or the first disease activity in a body of multiple sclerosis. And again, TB, syphilis, and sarcoid can also present as intermediate uveitis because they are masqueraders, good history, and then always keep in your mind that syphilis is something that might be very tricky to diagnose in Pakistan unless the patient agrees to getting the blood work done for syphilis. So these are all the cells they appear as floating balls, and they appear black simply because they are casting shadows on the retina, and the patient is basically picking up those shadows. And how do we manage this? Again, we need to give steroids, and topical steroids don't penetrate behind the lens, the natural crystalline lens. So you need to give oral or periocular, depending it's a bilateral condition or a unilateral condition. And you need to, again, gradually taper steroids. If it's an infection, syphilis, TB, you do appropriate therapy. If you specifically pick up multiple sclerosis, you have to give treatment for multiple sclerosis, which is IV intravenous steroids for 3 days plus oral steroids for 11 days. Again, more on this when we talk about multiple sclerosis in setting of optic neuritis. Or you can also give Avonex, which is interferon beta 1A or alpha, or beta seron, which is interferon B1B. And this is something that should always be kept in mind. Again, middle-aged females, think of multiple sclerosis. This therapy of steroids and periocular steroids is for the idiopathic unknown type of intermediate uveitis. Let's just talk about a bit about posterior uveitis. And posterior uveitis, again, we have talked about most of these causes. Toxoplasmosis is something we haven't talked about yet. So toxoplasmosis is basically a parasite, and the definitive host is a cat, and the intermediate host is a human. The causative agent is Toxoplasma gondii. It's an obligate intracellular protozoan parasite. You can get posterior uveitis either as a congenital disease, fetal-maternal transmission, intrauterine transmission, and you can also get it as an acquired disease. And the acquired disease usually has a lot of vitreous inflammation. In fact, so much vitreous inflammation that the picture has been described as head-like in a fog appearance of the focus of retinal inflammation. I'll show you a picture. Chronic cases, once the disease has run its course, present out as a scar of the actual inflammation that happened in the acute stage. And it's a unilateral disease generally, so the patient might not even know of the disease process because, again, most presentations are painless. Remember, this is a posterior uveitis. Unless there is spillover, there is no pain or redness. So the patient usually notices this a lot of time afterwards, unless the patient is usually, very aware of his vision. You can have reactivation of a congenital infection. So you have an active focus in next to a scar. I'll show you these pictures in a bit. And always keep in mind, TB, syphilis, and sarcoidosis can present as posterior uveitis. So good workup history is sort of essential. So how does a patient present? Again, if it's an acquired infection, obviously, you will have painless loss of vision. It will only become painful if you have anterior spillover. We've talked about spillover before. Floaters because of vitreous activity. And that painless loss of vision is usually of a visual acuity when the lesion is close to the macula or in the macular region close to the fovea, more appropriately. If it's a little far off outside of the macula, extramacular area, it's usually a problem with the visual field, and thus more difficult for the patient to pick up. Thus the disease remaining sort of asymptomatic for that patient and only picking it up when he actually closes one eye, or he notices a defect once the disease has sort of passed over, or he goes in for an examination and he finds out, hey, he has a lesion somewhere, which was not involving which was not in the macular area, thus patient wasn't aware of it. Congenital is something that's usually central and does affect vision, but since this is a congenital lesion, it only becomes apparent later in life when the patient becomes adult, or at least adolescent age, old enough to appreciate that vision in one eye is poor. So what's the therapy? You have option 2 in Pakistan, and visual rehabilitation depending upon where the scar is. So prismatic glasses which deviate light away from the scar are something that's useful. Prismatic glasses are something that we'll touch upon when we talk about strabismus, so you can see a picture and read more about it when we talk about it. But generally speaking, oral azathioprine alone is something that's given in Pakistan. Option 1, it can also be used, but it's usually option 2. Steroids you might find interesting. Well, if you have a lesion that's central close to the macula, you need to get rid of the inflammation quickly or you'll lose your central vision. So this is that head-like in a fog appearance. This is your retinal lesion and choroidal inflammation, retinal inflammation, and the vitreous activity is so much that it appears that this is a head like in a fog, and you can see an old lesion here and a new lesion developing next to it. This is a chronic stage lesion or even a congenital lesion. A congenital lesion is also macular, as we talked about, and this was an inflammation right here that became chronic. Treatment wasn't given or wasn't treated properly, and you are left with this. This patient will have very, very poor visual acuity because the foveal area is involved in addition to the macula. So these are the various differentials of a red eye. We have done this, and this. So use this table to differentiate based on simple torch examinations. Mostly, these are visible, all of these signs and symptoms on a torch examination, which help you to differentiate between those conditions. Do put this to good use. And thank you very much. I will see you next time in the next video session.